The first case is involving Wendy. I was sitting in my house one Sunday morning and received a text from Wendy, who was, again, a personal friend. And in the text, she basically said, hey, I think I did something to my foot, because she was doing what she called jumping lunges. And those jumping lunges, during the course of one of the landings, she said something hit the back of her calf like somebody shot her with a rubber band. She said she wasn't having much more pain than just burning, but she was telling me how her foot was weak and she didn't have as much force in stepping off. And ironically, about a year before, I had done one of the webinars for the AIUM here on tendinopathy, and I had looked through YouTube, and I'm going to share with the viewers the exact exercise that Wendy was doing when she experienced what she experienced. So those of you out there who might have the volume down, which because I'm talking so loud, or intensely, you've got to hear this. Hopefully this will play with the first hit.
I think, in our,
Go ahead.
In our current, COVID pandemic with, there's probably a lot of people doing home exercise, high intensity exercises like this. There's probably an uptick in patients presenting like Wendy.
Absolutely. And I find it ironic that the t-shirt says today is the day. Anyway, Wendy comes over to my house, mind you. I pull out the probe because I look at everything, and I take a look at her ankle, and clearly even the viewers have in their mind what they think occurred to both this young lady and to Wendy. But when she came over, she had no discoloration. She had very minimal swelling. It had been about 3 or 4 hours. She did have some weakness with push-off, but she could plantar flex her foot. I'm going to now take the actual diagram here as you get yourself prepped to go and do a demo for us. We're going to be taking a look, and you can see the linear probe at the very top and the orange call out under that anatomy. And we're going to see that the heel cord, or the Achilles tendon, is going to be run in long axis. So we would expect to see the fiber bundle of the Achilles tendon as it goes into the calcaneus, that's represented here by the number 2. We'll also see have access to see the Kager's fat pad that shows up here as number 3. And we're going to be scanning both distal and proximal with the Clarius L15 high resolution probe in order to get a feel for exactly what this looks like in real life. And those of you who are watching, I'm going to ask that you take a look at the dimension and take a look at some of the structures, because I'd like to bring Wendy's case in directly following. I'm turning it over to you now, Aron. You and the model.
Yeah, walk me through this, Greg. So how do you do it? You start at the calcaneus here? Yeah.
Yes. I do want to see that the orientation of your probe is perfect. One end of it needs to be down on the heel, and the other one needs to be
to the head here.
Yeah, that's what we're looking for. Right. And now, obviously coming into view here, in the middle of the screen, we can see the fibers kind of take a 45-degree plunge into the calcaneus. And what I want you to see is that the fibers only attach to the right-hand half of this bright line. So the part where you see the fibers go dark in the image, it's where the fibers take an angle and go directly down into the periosteum.
But that's what we're seeing right in the middle of the screen here.
Yeah, the darkness is where those fibers start to ricochet the sound away from the returning readers of the probe. But the important thing to realize is to the left of that, you're seeing this dark line. That dark line above the bright line is actually fluid from retrocalcaneal bursa. And as you slide front to back, you're actually able to see that dark little mass to the left. Yeah, you're doing a great job of bringing it on view here. That is the fluid that when he points his toe and brings his toe back, if Hunter can push his toe out easy, nice and slow, push your toe out, good. And you'll see that that fluid will come out. And as he then brings that back, that part of the calcaneus will come again in compression to those fibers. That compression is going to be pivotal for you to see, because in just a moment, I will show you why that's incredibly relevant to the physical therapist working on patients that have heel cord pain. Go ahead.
Yeah, and then so in a normal patient, I mean, we're talking like there's 1 ml of fluid in there or less. That's such a small target to see. You have to like really see it in such high resolution to see that factor.
The fact that you can even see it on a normal patient is phenomenal, but it's kind of like the oil can. It's sitting there in front of the calcaneus, just ready to brush some more oil up onto those fibers. But now you're
so walk me through the rest of this Achilles. Yeah, so this is the mid-span.
It's a good view as you can start to see the fibers come a little bit closer together, but that cloudy area below that is the Kager's fat pad.
This triangle.
And providing, and the darker colored material to your left, those are the flexor tendons. So you can see the fibers at the top. You can see that cloudy area, which is the Kager's fat pad. You can see the darker structure to the left, which is your flexor, your toe flexors and the digit flexors. And you can see the hyperechoic echo of the distal talus. So I want you guys
down at the bottom. That's that bright white line down at the bottom of the screen is the talus.
That's the distal talus. And I want the viewers to take a look at that long band at the top, going from right where it's wider to the left. You can actually almost count the fibers, the spatial resolution, and the spatial resolution you're looking in right now compared to any MRI, even the Max Teslas, is just phenomenal.
Yeah.
Anyway, good job with that, by the way.
That's a nice looking Achilles. Yeah.
It is. Yeah.
All right, great. Here, we'll go back to your slides.
And what I want to show the viewers is actually how things looked with Wendy. As soon as I have access back, if you can remember that last picture that you did, and if you can see my arrow here, you can see that dark area that I was telling you was the flexor tendons. That was that bundle right here. And what we didn't see represented in this particular diagram is Kager's cloudiness. In your model, we did. But I want you to keep in mind that the fibers up here are the fibers to the left on this video display. And I'm going to go ahead and hit play on this. And I want you to notice that when the toes go down into plantar flexion, the flexor tendons themselves are going to move.
Yeah, okay.
So the top, you can see the flexor tendons take the toe into plantar flexion, but what you can't see is that strand across the top of the screen, and you're seeing the actual stub of the distal component of the Achilles tendon right there.
And this is what I love about ultrasound, is the dynamic ability to evaluate, right? It's not just walking into the radiology suite and getting a film taken, but you just sit and watch while you're doing your exam, right? It's as if, like the mechanic, you're listening to the sound while you're turning the ignition, you're watching the thing spark, or like seeing where the sound's coming from, what's happening.
It's exactly right in front of you. And I remember when it would first shock me that that's just like Netter drew, or that's just like the anatomy book, which was crazy because anatomy was drawn. I do want to bring up the fact that there's so many complex differentials that to a physical therapist who's dealing with how do I manage these patients, it's not just important to confirm that what we thought was the case, but it also has nuances of treatment. I'm going to take it to the next slide here, because I want you to notice that the orange framed video here is exactly related to the diagram to the top left. And you're seeing that fluid bundle that we saw on your demo show up to the left, but you're also seeing at the insertion point of the Achilles tendon, there's a large bony knob. That's an exostosis. And you'll also see, if we go to the right, this is actual power Doppler, a component of imaging that brings the ability to identify whether or not the tissue itself is having blood flow to it. So I'm going to play again the cross-sectional axial view of the distal Achilles tendon.
Normally the Achilles has no blood flow, right? So if I had thrown Doppler on there, it would just, nothing would light up.
There shouldn't be, because fibers are fed not by passive nutrition, not by active energy, which you can certainly see represented here, that if this person were to go into dorsiflexion doing your classic Achilles tendon stretch, this would do nothing more than light it on fire even more. So I want to move on now. I don't want to spend, I've got so much material that I'm feeling like I'm wasting it on this, as opposed to the mid-span And you can see that same view in the orange call out here, if you can see my pointer, that you were at your very last. This is a long axis view. We'll go to the short axis anyway. You can see the call out and the fibers on the far right. You can see the fluid and the effusion. And in this case, there was some partial tearing going on. But the point I'm trying to make is to be able to differentiate the mid-span lesion from the insertion lesion takes incredible value and places it into the hands of the physical therapist.